Yes, sorry. Several physios got together and we discussed particularly problems post-knee surgery. And one of the things that we all came out with was the fact that the patient's expectations were a lot higher, because although hips you could just sort of pop out after a few days and get up and mobilize and the pain goes away magically and they're back to their normal routine. Knees, particularly total knees, aren't like that. And yet a lot of the patients were led to believe, perhaps wrongly, that this was what was going to happen. So their expectations were not really, shall we say, put in perspective. And therefore, quite a lot of the feedback was, well, nobody told me it was going to be so much hard work, nobody told me it was going to be so painful, if I'd really thought about this, maybe I wouldn't have gone through with it. I mean, obviously, depending on when you actually get to see that patient in the recovery phase, but it was something that we decided that, in fact, there wasn't enough realistic information given about knees, of actually how hard work it was to actually get properly rehabilitated.
Now, these are questions about the patient experience.
Well, actually, I think that's a terribly important point. And you didn't mention it in your list of the uses of problems. I think one of the most important uses of problems is actually helping patients to have realistic expectations of, and we know there's lots of studies.
You're including patient experience questionnaires as the...
Well, because we know that a lot of people who undergo knee replacement are disappointed because they do have overly high expectations. I think one of the benefits of the research you're doing is that this can be fed back to patients to help them to make a decision about whether or not to have the operation. I've been saying this to the Department of Health for millions of years and they still don't see it as, and I think you're right, there is a risk that they'll want to publish these as league tables and so on. Yeah, I think that's missing the point.
So that patients would have a graph, say, of where the scores are likely to be, well, I think 6 or 12 months on.
That's really my question, actually, because I think translating this into a form that will be useful and meaningful to patients needs quite a lot of thought and work. And I'm just wondering whether you know of anybody doing it yet.
I've given it quite a lot of thought. And I thought that if one, for instance, produced graphs of where people are at 12 months after certain operation, you really need a small book of graphs. One's for people of over a certain age or in different age bands, because people in different age bands will benefit to a different extent probably, depending on what the underlying diagnosis was or reason for the operation may influence what the result will be. And there isn't a one-size-fits-all in the graph.
Well, I think you can actually, I think I think you could incorporate this into decision aids for patients, and there's oodles of research on that.
Yes.
How to do that. But the difficulty is actually, when you've got a score, an average score.
Yes.
How do you make that?
It may be nobody. The average score may be nobody.
This is really important actually, because actually we are all about to be flooded with the results of this big initiative. So every hip and knee replacement is having these PROM scores done on them. And the question is, what's it going to mean? How is it going to better inform both clinicians, people treating patients, physios, doctors, whomsoever, and also patients in terms of choosing, is this the right operation for me? And the danger, I think, and I think this is behind Andrew's point, in the way it's constructed at the moment, is that it may not be set up to give us best value, really. And the issue of expectation is crucial to this, because it might be, indeed some of the work we've done with shoulders has shown that for a group of patients who we counseled very carefully before an operation, who ended up without a significant improvement in their movement, and therefore not a fantastic leap in their score, they were delighted with the operation because it got rid of their night pain. Because what we said to them before the operation was, this operation is designed to get rid of your night pain, it won't make you move anymore. And they went into the operation on those terms. and therefore their expectations were met and they were satisfied. And yet, if you put them on a score, a league table, which was just a score, it may look as though that operation wasn't particularly good. So I think there is further work to be done, and I think Andrew's right. I think that we will learn from what these scores are telling us, but we shouldn't leave it at that. We need to enhance and improve our methodologies so that we better inform ourselves. I think that's the position I think we're in now.
But sorry, put my mic up.
You next, and then there's something.
Sorry. When a patient hears that they could possibly benefit from having a knee replacement, for example, patients, in my experience, because I've been on both sides of the line, I have a patient who's had 2 knee replacements and they are absolutely brilliant, but brilliant. There's nothing I can't do with my 2 knees, and I'm delighted that I have them done. But I think that I was bold enough to say to myself, if I leave this another year or 2, I would have left it too late. Because I think some people have the fear of having an operation. I genuinely don't think people have a recognition of the fact that the surgeon has done his job, but they have got a big job to do subsequently. And it is only by doing that and really, really, really working at it are you going to get, obviously it won't be true for everybody, but good results will come out of perseverance and really carrying on doing the exercises and everything else. And I just think that the patients that I've met, A, they leave it too late because for some reason it holds them back, but also they don't seem to recognise that that although they've not got a quick fix, they think, oh, it's been done, therefore I should be ordinary and quite normal and everything should be fine. They haven't actually anticipated that they have a great contribution to make towards the good outcome, you know. And they often think, oh, well, that hurts, or I won't bother then, I won't do it because it hurts. Instead of just trying to actually work and push the boundaries just a little bit all the time.
This is the last question for this section, so that's a question.
How did you score patient satisfaction of their stay in the hospital during the time of the refurbishment of the hospital? Because environment, you know, I mean, I had one when it was cheaply going down to a loo right down the corridor and things like that, and now it's very much better. The stay would be very much better.
That's a really, really good question. It's about the environment, and of course it's not specifically what we've just been talking about now, which is how well the operation do, but maybe Karen, do you have a comment on that?
Annually, from the Department of Health, send out a snapshot, a percentage of patients are given a patient experience survey, and that is quite structured and asked specifically about how well the staff communicated, whether they polite, whether they explained things well, about written information given, and it has quite a section that's asked about cleanliness, about facilities, about dignity and privacy. So, yes, undoubtedly, some of those hard scores have improved their end because the building is so much nicer, and it's how hard the staff tried. It was hard to get to a score when you're in a drafty building with tough buildings up over it. And we had a period where those estate-related scores were quite poor. And what we have to do is to disaggregate the ones which are about things within our gift to change, so staff reactions with patients and things can be really shocking. So it does. It's easier to get a good score in a shiny, nice building.